Endometriosis, painful periods and chronic pelvic pain. Endometriosis doesn't announce itself loudly at first. It begins as a whisper. Period pain that feels heavier than it should, cramps that don't respond to painkillers, a deep ache that lingers long after bleeding stops. Many women grow up believing this is normal, that suffering is simply part of womanhood, that pain is the price of having a uterus. But endometriosis is not normal pain, and it is not rare. Endometriosis is a chronic inflammatory disease in which tissue, similar to the lining of the uterus, grows outside the uterus, where it does not belong. This tissue can attach to the ovaries, fallopian tubes, pelvic lining, bladder, bowel, and sometimes even beyond the pelvis. Unlike the uterine lining, this tissue has no natural exit from the body. Each month, it responds to hormonal signals, especially estrogen, by thickening and inflaming, but instead of being shed, it becomes trapped. The result is inflammation, scarring, nerve irritation, and pain that can be profound. This is why endometriosis pain often feels different from typical menstrual cramps. It is deeper, sharper, burning, sometimes stabbing, sometimes crushing. And for many women, it doesn't end when the period ends. Painful periods are the symptom most people recognize, but endometriosis is far more complex than menstrual pain alone. Many women experience chronic pelvic pain, pain that exists outside of menstruation, pain during or after sex, pain with bowel movements or urination, lower back pain that radiates down the legs, fatigue that doesn't improve with rest, a bloated, distended abdomen, often called endobelly, digestive symptoms that mimic irritable bowel syndrome, difficulty conceiving. What makes endometriosis especially cruel is that the severity of symptoms does not always match the visible extent of disease. Some women have extensive endometrial lesions and minimal pain. Others have microscopic disease and debilitating symptoms. Pain is not imagined. It is neurological, inflammatory, and hormonal. Endometriosis is fueled by estrogen, but it is not just a hormonal condition. It is also an immune disorder. In many women, the immune system fails to clear misplaced endometrial-like tissue. Instead of resolving inflammation, immune cells release cytokines that further sensitize nerves and promote lesion growth. Over time, scar tissue, called adhesions, can form, binding organs together that were never meant to be connected. The pelvis becomes less flexible, less mobile, more painful. This is why pain can persist even when periods stop, even when hormones are suppressed. Endometriosis changes the architecture of the pelvis and the sensitivity of the nervous system. Pain pathways become amplified. The body remains on high alert. Despite affecting an estimated 1 in 10 women worldwide, endometriosis remains one of the most underdiagnosed conditions in modern medicine. On average, it takes 7 to 10 years from symptom onset to diagnosis. Women are often told their pain is normal, exaggerated, stress-related, or psychological. Ultrasounds frequently appear normal. Blood tests don't reveal the disease. The gold standard for diagnosis remains laparoscopic surgery, an invasive procedure many women are never offered until symptoms become unbearable. During those lost years, women adapt. They plan their lives around pain. They miss work. They avoid intimacy. They internalize the belief that their bodies are unreliable, broken, or betraying them. The emotional toll is immense. Anxiety and depression are common, not because the pain is imagined, but because living with unrelenting, uninvalidated pain is exhausting. Endometriosis can also affect fertility, though not all women with endometriosis are infertile. Inflammation can disrupt ovulation, alter egg quality, distort pelvic anatomy, and interfere with implantation. For some women, infertility is the first clue that something has been wrong for years. Treatment for endometriosis is not one size fits all. There is no single cure, but there are ways to manage symptoms and slow progression. Hormonal therapies aim to suppress estrogen and reduce lesion activity. Pain management addresses nerve sensitization and inflammation. Surgical excision, when performed by experienced specialists, can remove endometrial lesions and restore anatomy. Lifestyle interventions that reduce inflammation, support gut health, and regulate stress can play a meaningful supportive role. Care must be individualized, multidisciplinary, and compassionate. What does not help is dismissal. What does not help is telling women to tolerate pain. What does not help is reducing a systemic disease to bad periods. Endometriosis is not weakness. It is not low pain tolerance. It is not anxiety. It is a real, complex, whole-body condition that sits at the intersection of hormones, immunity, neurology, and inflammation. And perhaps the most important truth is this: pain is information. When the body repeats the same signal month after month, year after year, it is asking to be heard. Endometriosis teaches us that listening, early, seriously, and without judgment, can change lives. For many women, receiving a diagnosis is not just medical. It is emotional. It validates years of suffering that went unseen. It gives language to an experience that once felt isolating, and it opens the door to care that honors both science and lived reality. Endometriosis is not rare. Women's pain is not exaggerated, and silence has never been a cure.